Right, and you know it's different than I'm coming up tomorrow. Maybe you haven't volunteered, you haven't thought about that before you go fill in. But here's the depends on this, and we'll have it.
Of topics.
On this side.
Yep.
Thank you.
Here.
Go that way.
Got it?
There we go.
That. Just in case.
Just don't want to kill anybody stepping back.
Yep, that's it. Yep, they got
Call the meeting of the Health Subcommittee to order, and today we're having a hearing on a number of public health bills that are priorities of our committee members. So I'll recognize myself for an opening statement. Given that this is the second hearing of the day, I'm going to keep my remarks very brief so we can hear from our witnesses from the Department of Health and Human Services. I do want to express my gratitude to HHS not only for providing helpful feedback and comments on the bills we plan to consider this week, but also for their flexibility with this hearing. The hearing was originally scheduled for yesterday, but the witnesses from HHS agreed to testify today late in the day to accommodate member schedules. And we truly appreciate your clear commitment to be accessible and available to the Energy and Commerce Committee and look forward to your testimony. The legislation that Health and Human Services will be commenting on today encompass a broad number of public health priorities that will strengthen and enhance research related to pediatrics, heart disease, multiple sclerosis, scleroderma, bone marrow failure, and cancer. Research and treatment is informed by strong data, and so HHS will also comment today on legislation to improve the collection of data for health disparities. And finally, we'll hear from the Department on the critical services that public health veterinarians provide in our communities to protect the public health. Congressman Tammy Baldwin and I have worked together on legislation to promote an adequate supply of public health veterinarians who work in subject areas that have an impact on human health by ensuring access to grants and loans. And I'm pleased that our staff and the minority are finalizing consensus language on this shared goal. I would like to ask unanimous consent to enter into the record a letter from the Association of American Veterinary Medical Colleges and the American Veterinary Medical Association on the revised version of H.R. 2999. And without objection, so ordered. And I will yield to our ranking member, Mr. Shimkus.
Thank you, Mr. Chairman. As I promised this morning, we would also just put on the record that we appreciate the folks from Health and Human Services showing up. We are still anxiously awaiting the presence of the Secretary to help us discern her intentions on the health care law. It's been a long time since it's now been passed into law, and she's involved in the administration of that. Numerous letters. And we would like to at least start addressing some of those issues, especially those that we know need to be fixed. We know there are provisions that need to be fixed. There's bipartisan discussions on both sides, and we should be about that business. But since that's not going to happen anytime soon, I want to thank you for also moving this to a time when members have no excuse for not being here. So if they're not here, they're absent. Fly-in days are a different position by most members, especially in this environment. At least now we can hold them accountable for not showing, because we all should be here. And again, thank you for changing your schedule. We've been working hard on this whole list of 20 or so bills, and we're making great headway in trying to move these expeditiously. I'm just going to lay out some of the general concerns. Spending in our national government is the primary concern of the population out there. I mean, at least in my district, and I think it's safe to say across the country. You can't spend money, theoretically, buy the civics books if you don't authorize. Anytime you increase authorizations, you increase the ability to spend more money. So having said that, the compelling arguments for increasing authorizations better be compelling. I hope to move eventually to a time where instead of having offsets, we move to offsets, where we take an authorization and we remove one that doesn't really hold water or isn't applicable anymore. And that would be a good signal to the public that we're not only trying to move government spending where it should go, but we're also recognizing the fact that we probably authorize spending and spend money in inappropriate ways. What some of the negotiations are is looking at authorization levels and inflationary adjustments, and I think in those areas I think we can get to some agreement. Some bills talk about additional granting to states. It's going to be a problem in this environment, getting Republican support for additional spending. I'll end. There's also some that tread very close to abortion discussions and Hyde Amendment issues. We would think that that would not be helpful in moving bipartisan bills to the floor. And with that, Mr. Chairman, I'll stop and I'll yield back my time.
Thank you, Mr. Shimkus. We have some other members here. The gentleman from Georgia, Mr. Barrow, is here first.
I thank the chairman. As Mr. Shimkin says, I have no excuse not to be here, but I have nothing to add to what's been said. It's at the table for our discussion today, so I'll waive an opening. Thank you.
Thank you. And we have Mr. Green from Texas.
Thank you, Mr. Chairman. And I have to admit, I wasn't listening to my colleague from Illinois, but I was actually outside, and I'm glad I'm here and present. I want to thank you for holding a hearing today on several pieces of health care legislation pending before the committee. I'm a strong supporter and co-sponsor of many of the bills. I'm glad we're moving these bills through the legislative process. I don't want to take too much time, but I want to point out one piece of legislation we will be discussing today. I've been working with Representative Hank Johnson on H.R. 5986, the Neglected Infections of Impoverished Americans Act of 2010. Since we were marking up the health reform bill, and I included this legislation as an amendment. Recently, Chairman Waxman and Representative Gingrich signed on the legislation as original co-sponsors. I would like to thank them for their efforts on the issue. H.R. 5986 would require HHS to submit a report to Congress on the current state of parasitic diseases that have been overlooked among the poorest Americans. The 2008 study by George Washington University and the Sabin Vaccine Institute identified high prevalence rates of parasitic infections in the poorest areas of the United States and along our border regions. Scientists estimate there are maybe as many as 100 million infections of neglected diseases identified in our legislation, including Chagas, cystic ursosis, toxicarsis. Anyway, there are a whole bunch of them, and I'd like the full statement to be placed in the record. These diseases and other neglected diseases of poverty collectively infect over 1.7 billion people around the world, but they disproportionately affect minority and impoverished populations across the United States, producing effects ranging from asymptomatic infection to asthma-like symptoms, seizures, and death. This study is especially important because these neglected diseases receive less financial support than they deserve. A mere $231,730 of research funding was allocated by the NIH since 1995. The discrepancy in funding is known as the 10-90 gap. A mere 10% of the global health research dollars is directed toward diseases affecting 90% of the global population. The Neglected Infections of Impoverished Americans Act of 2010 would provide an update evaluation of the current dearth of the knowledge regarding epidemiology in these diseases and the socioeconomic health and development impact they have on our society. I want to thank our witnesses for appearing today, and I'd like to submit 2 letters of support for H.R. 5986. For the record, one letter is from the University of Georgia and the other is from the University of South Alabama. And again, thank you, Mr. Chairman. I yield back my time.
Without objection, so ordered on the 2 letters. And next is our subcommittee vice chair, Ms. Capps.
Thank you, Mr. Chairman, for holding this hearing. And I would like also to ask unanimous consent to enter 2 letters into the record, one in support of H.R. 1032 and the other in support of H.R. 2941.
Without objection, so ordered. So
I am a co-sponsor of many of the bills before us today, and I urge us to act swiftly to pass them out of committee. I want to specifically thank you for including 2 bills that I have sponsored on the agenda. The first is H.R. 1032, the Heart for Women Act, which I am proud to say has broad bipartisan support, including every single Republican and Democratic woman on this committee. It focuses on expanding CDC's Wise Woman program, which has been proven so effective, and on ensuring that FDA is evaluating all new drug and device applications for how they affect women and men differently. Working closely with the majority and the minority committee staffs, I feel confident that we have made solid changes to this legislation that should make it sort of a no-brainer for unanimous passage. The other bill is H.R. 2408, the Scleroderma Research and Awareness Act, which also has strong bipartisan support and has been modified to address concerns of the minority and majority alike. H.R. 2408 would promote further NIH research into this debilitating disease and promote public awareness of scleroderma through the CDC. Thank you again for considering these bills in today's hearing. I look forward to passing them out of committee and ultimately the House. And if you wouldn't mind an additional just statement, because unfortunately Congresswoman Eshoo had a family emergency, and I would like to voice my support for her legislation, H.R. 211. With the strong support of United Way and 251 bipartisan co-sponsors, the Calling for 211 Act builds on existing state and local efforts to connect people with services and volunteer opportunities. The legislation provides federal matching grants, augmenting existing funding from state and local governments, nonprofits, and the business community. With this bill, 211 will finally become a truly national system. And I yield back.
Okay, without objection, so ordered. And all members of the subcommittee's statements who desire to enter them into the record will be entered into the record without without any objection. The gentlewoman from Wisconsin, Ms. Baldwin.
Thank you, Mr. Chairman. I have two bills before the committee today, and both are deeply important to me and many others, and I'm delighted that the committee is considering them. H.R. 2999, the Veterinary Public Health Workforce and Education Act, represents a comprehensive solution to ensuring that the veterinary public health workforce can meet vital public health challenges. We worked across the aisle to draft a manager's amendment that will serve as a good first step and help attract and retain more veterinarians into public health careers. I thank you, Mr. Chairman, for your support in this effort, as well as my friend and colleague from Pennsylvania, Mr. Murphy, who is a key leader in this legislation. Second, the Health Data Collection Improvement Act would authorize HHS to collect, where practicable and appropriate, information on sexual orientation and gender identity for participants in health programs and health surveys. This is an issue that I've brought to this committee's attention a number of times over the past few years. Currently, no federal health survey or federal health program collects data on sexual orientation or gender identity. As a result, we are left with gaping holes in our knowledge base on LGBT health. The federal government must have basic information on the health of all Americans in order to help address these issues, especially for those who may face discrimination and stigma in the healthcare system and outside the healthcare system. Again, thank you, Mr. Chairman, for considering these bills, and I look forward to hearing from our witnesses today. I yield back.
Thank you. The gentlelady from Illinois, Ms. Schakowsky, care to make an opening statement?
Yes, thank you, Mr. Chairman. I am supportive of all these bills, but I wanted to highlight H.R. 2010, the Arthritis Prevention, Control, and Cure Act, and thank its sponsor, Representative Eshoo, who couldn't be here today, for her leadership. She's attending a family funeral. 46.3 million Americans, including 300,000 children, are living with this painful disease. Arthritis is the #1 cause of disability in the United States and costs our economy $130 billion a year. I'm a co-sponsor of H.R. 1210 because it helps address those problems. It includes competitive grants to support the prevention, control, and surveillance of arthritis, and gives NIH the authority to expand research activities surrounding juvenile arthritis. I look forward to hearing from our witnesses today and to consideration and passage, we hope, of the Arthritis Prevention, Control, and Cure Act tomorrow. I yield back.
Thank you. Gentleman from Ohio, Mr. Space.
Thank you, Mr. Chairman. Appreciate your efforts in holding this hearing on a number of important bills. Today, our subcommittee is taking under consideration a number of bills focused on improving public health efforts in our nation, and addressing public health is no simple task right now. Childhood obesity rates are on the rise. Diabetes is rapidly becoming epidemic. Long story short, there are a number of disturbing trends out there that give all of us significant concerns about the future of our healthcare system. That's why I'm extremely pleased that Chairman Pallone has offered us today's hearing as an opportunity to look at one of the bills I've sponsored along with my colleague from Nebraska, Mr. Terry, H.R. 6012. This legislation is designed to reduce the number of seniors in this country with undiagnosed diabetes, and it's easy to see why we're doing this. We're spending upwards of $200 billion a year now combating diabetes in all forms. That's more money than we spend in Iraq in any given year during our wars. Figuring out a way to deal with this in a common-sense way that also mitigates the extensive human suffering that accompanies this epidemic disease is vital, and I appreciate the opportunity to address it today and take this up tomorrow in the markup. I yield back. Thank you, Mr. Chairman.
Thank you. I think that's all the members that we have, so we'll go to our witnesses. Welcome to the subcommittee hearing. Let me introduce each of you. Starting on my left is Dr. Lawrence Tabak, who is Principal Deputy Director of the National Institutes of Health with the U.S. Department of Health and Human Services. And then we have Dr. Ileana Arias, who is Principal Deputy Director of the Centers for Disease Control and Prevention, again with the U.S. Department of Health and Human Services. And we have Dr. Marsha Brand, who is Deputy Administrator for Health Resources and Services Administration with HHS. And then I have, my note here says available for SAMHSA-related questions is H. Wesley Clark, who is, oh my, you have so many degrees, I don't even know where to begin. You're a doctor, an MD, a lawyer, MPH, CAS, FASAM, Director of the Center for Substance Abuse Treatment, Substance Abuse and Mental Health Services Administration at the department again. So we try to keep it to 5 minutes. Your statements become part of the record. If you want to submit additional written comments, you may. And I'll start with Dr. Tabak.
Mr. Chairman and members of the subcommittee, thank you. I'm honored to attend this hearing with my colleagues to discuss issues relating to legislation pending before this committee today. NIH and its research partners, patients and their families, scientists and their research institutions have collaborated to produce scientific understanding and medical innovation that has prolonged lives, reduced human suffering, and improved the quality of life for millions. Due to NIH research, mortality from heart disease and stroke has been cut by more than half in the United States. Today's new cancer therapies arrest the disease and prolong human life, so cancer survivors number in the millions. Our blood supply is far safer because of tests for HIV and hepatitis B and C. NIH-funded science has also helped people make lifestyle changes that promote health, such as eating less fat, exercising more, and quitting smoking. These are a few examples of NIH-funded discovery that have transformed medical care. NIH owes much of its success to the advocacy and strong support of millions of patients and their families. Historically, NIH has also been championed by Congress and has received strong bipartisan support. As a community, researchers on the NIH campus and around the country are very grateful for such support and are mindful of the responsibility we bear to be good stewards of the taxpayers' investment in medical science. NIH has also been given the flexibility and indeed the explicit responsibility to exercise the scientific community's best collective judgment in determining research priorities. These decisions are made in a dynamic matrix of scientific opportunity, public health needs, burden of disease, and the input and perspective offered by patients, their families and advocates, scientists, and public health experts. First and foremost, NIH must respond to public health needs, which are addressed through a complex balance among basic, transformative, and clinical sciences. Second, NIH applies stringent review provided by outside scientists who are experts in a given field evaluating the quality of all research proposals considered. Third, scientific history has repeatedly demonstrated that significant research advances occur when new findings, often completely unexpected, open up new experimental possibilities and pathways. Finally, we strive to ensure the diversity of NIH research portfolio, as we simply cannot predict the next scientific revelation or anticipate the next opportunity. Having briefly discussed how NIH sets research priorities, I would like to review some of the research we are currently conducting in several of the disease areas that are addressed by the bills pending before the subcommittee. Juvenile idiopathic arthritis has no definitive cause and strikes children before they turn 16. The National Institute of Arthritis and Musculoskeletal and Skin Diseases funds a broad range of research from basic studies of underlying mechanisms of arthritis to clinical studies exploring new treatment options. Scleroderma is a group of diseases in which the connective tissue that supports the skin and internal organs grows in a highly abnormal manner. NIMS has supported the Scleroderma Family Registry and DNA Repository, which has enabled researchers to conduct genome-wide association studies of scleroderma, which will provide insight into which genes are responsible for susceptibility to scleroderma and which biological pathways may cause organ damage in the disease. Children deserve to be born healthy and to achieve their full potential for healthy and productive lives. NIH, led by the National Institute of Child Health and Human Development, supports the bulk of research on normal and abnormal child health and development. The majority of NIH's institutes and centers include pediatric research in their portfolios. Regarding the subcommittee's interest in type 2 diabetes research in minority populations, NIH, primarily through the National Institute of Diabetes and Digestive and Kidney Diseases, is investing significant resources in multifaceted research on this disease in minority populations, as well as obesity research. Let me conclude by offering the thanks of NIH, the biomedical research community, and the millions of American patients and their families for your unwavering dedication. I am personally grateful for your time and attention this afternoon and look forward to your questions. Thank you.
Thank you, Dr. Tabak. Dr. Arias?
Mr. Chairman, Ranking Member Shimkus, and members of the subcommittee, thank you for the opportunity to testify today along with my colleagues from the department. This is an exciting time to be engaged in prevention and public health. We are currently improving our immunization programs, taking steps to reduce healthcare-associated infections, rebuilding our nation's public health infrastructure, and supporting communities across America as they tackle critical problems like obesity and youth smoking. In the years ahead, millions more Americans will have coverage for preventive services. We are anxious to take advantage of these opportunities and to track the health gains that this focus on prevention can bring. I'm pleased to be here as you consider legislation to address certain health issues of concern. We appreciate the interaction that we've had with members of the subcommittee and staff on these bills, and we greatly appreciate the opportunity to share our public health expertise with you. CDC's mission is to promote health and quality of life by preventing and controlling disease, injury, and disability. Working closely with our sister agencies, CDC is committed to reducing the health and economic consequences of the leading causes of death and disability, thereby promoting a long, productive, and healthy life for all people in the country. Today, I want to provide you with a broad perspective on CDC's current efforts to achieve these goals and to discuss CDC's work that relates to many of the bills that you're considering. First, I'd like to review a few of CDC's current initiatives that demonstrate the range of public health challenges that we're facing. CDC has begun an effort to achieve measurable impact quickly in a few targeted areas, which we refer to as winnable battles. These winnable battles were selected based on the scope of the burden posed by these health threats and, equally importantly, CDC's ability to make significant progress in improving relevant health outcomes. To date, CDC Director Dr. Thomas Reeden and CDC leaders have identified 6 winnable battles and have outlined a number of achievable priorities and opportunities for each of these. The 6 battles are, first, prevention of HIV, second, motor vehicle collisions, third, the prevention of healthcare-associated infections, third, the control of tobacco. Fifth, prevention of teen pregnancy. And then lastly but not least, the prevention of obesity, the improvement of nutrition, physical activity, and food safety, which includes diabetes, a critical and costly health problem that the subcommittee is working to address today in 3 legislative initiatives advanced by Representatives Engel, DeGette, and Space. In many cases, we have known effective solutions. In others, such as gestational diabetes, work remains to identify the path to prevent the issue. Second, the CDC leadership has identified 5 strategic priorities to help achieve these winnable battles and to support other public health priorities. The first of these 5 priorities is applying effective policies. The science currently tells us that effective policies in areas such as tobacco control, motor vehicle safety, healthy eating, and physical activity in schools and communities can save lives and reduce health care costs. We are increasing our effectiveness in this area. The subcommittee today is considering a bill on methamphetamine education and treatment, which is very relevant to CDC's effort to identify policy interventions that can reduce the health toll from overuse of prescription medications. Second, providing leadership in global health. Global public health investments have a direct benefit on U.S. public health and U.S. national security. Programs in AIDS, malaria, and pandemic preparedness have improved health systems throughout the world and strengthened our outbreak response. CDC has specifically created a new global health center to accelerate work in this area. Third, with the support of Congress and the new Public Health and Prevention Fund, CDC is making investments that will significantly address the third priority, improving and strengthening surveillance, epidemiology, and laboratory capacity. This is essential and critical to our ability to identify health problems and to develop, and importantly, to track the progress of solutions. Many of the bills being considered by the subcommittee today explicitly call for improvements in the availability of data on public health issues, such as Representative Burgess's work with Mr. Van Hollen on surveillance of neurological diseases, Representative Baldwin's initiative to expand data collection on sexual orientation and gender identity, Representative Eshu's proposal to advance arthritis surveillance, and Representative Johnson's focus on neglected diseases, and Representative DeLauro's initiative on birth defects. We're confident that any of these specific mandates would benefit from CDC's current focus on improving national surveillance capacity. State, local, tribal, and territorial health agencies collect surveillance data, they conduct laboratory testing, and they investigate outbreaks and take public health action. They essentially are our boots on the ground. Because these CDC partners are critical to implementing public health programs across the country, many of the measures before the subcommittee today rely on grants to these agencies to achieve the bill's purposes. These measures include Representative Space's work to increase research and data collection on the widespread occurrence but unclear origins of gestational diabetes, and Representative Eshu's initiative to implement a state-based call-in system providing individuals with information about human services. We're confident that CDC's focus on working with our partners to improve the performance of public health agencies would improve capacity relative to these specific initiatives. Our final priority is to use the above strategies and the focus on winnable battles to have a significant impact on the leading causes of death, illness, injury, and disability. CDC would be interested in working with the subcommittee to ensure that any initiatives being considered today could build on successful efforts to address high-burden health problems. For example, this week, CDC launched a campaign addressing prevention of gynecological cancers, and we will also be addressing heart disease through the Wise Woman program. These programs address cancer and heart disease, which are among the leading causes of death in our country. With the support of the Congress, we have made progress in addressing the nation's most pressing health needs, and the focus I have outlined, supported by investments in the Recovery Act and the Affordable Care Act, we feel we are poised to accelerate these gains. I appreciate the opportunity to discuss CDC's work with you and look forward to working with the subcommittee as you consider the legislative initiatives before you. Thank you.
Thank you, Dr. Arias. Dr. Brand? I think it's either not on or not close enough to you.
Good afternoon.
Yeah, a little closer.
Mr. Chairman.
Is it on?
Yeah.
Green light? Okay.
Green, yes, sir. Mr. Chairman, members of the subcommittee, thank you for the opportunity today to testify on behalf of the Secretary for Health and Human Services, Kathleen Sebelius, and Dr. Mary Wakefield, the Administrator of the Health Resources and Service Administration. I'm Marcia Brand. I'm the Deputy Administrator at HRSA, and I'm pleased to join my other department colleagues in appearing before you today. The Health Resources and Services Administration helps the most vulnerable Americans receive quality primary health care without regard to their ability to pay. HRSA works to expand access to health care for millions of Americans, the uninsured, the underserved, and the vulnerable. The individuals we serve include mothers and their children, those living with HIV and AIDS, and residents of rural areas. HRSA recognizes that people need to have access to primary health care, and through its programs and activities, the agency seeks to meet these needs. HRSA delivers on its obligation to address primary care access through 6 bureaus and 13 offices that comprise the agency. HRSA helps to train future nurses, doctors, and other health providers, placing them in areas of the country where health resources are scarce. The agency collaborates with government at the federal, state, and local levels, and also with community-based organizations to seek solutions to primary health care challenges. HRSA provides leadership and financial support to healthcare providers in every state and every U.S. territory. HRSA's vision for the nation is healthy communities and healthy people. Our mission is to improve health and achieve health equity through access to quality services, a skilled health workforce, and innovative programs. The agency seeks to further our vision and carry out our mission through our 4 major goals: improve access to quality care and services, strengthen the health workforce, build healthy communities, and improve health equity. At HRSA, we believe that primary care is more than having a place to go when you are sick. We view primary care as the Institute of Medicine does, providing integrated, accessible care services by clinicians who are accountable for addressing a large majority of personal health care needs, developing a sustained partnership with patients, and practicing in the context of family and community. In addition to supporting the provision of direct patient care, HRSA focuses on implementing programs that increase the number of primary care providers, including the National Health Service Corps. HRSA programs train primary care providers, long-term care workers, and individuals skilled in providing care for the elderly. HRSA programs also support loans and scholarships that encourage disadvantaged individuals and those from diverse backgrounds to enter into the health professions. HRSA is committed to making sure that the U.S. has the right clinicians and the right skills working where they are needed most. HRSA-funded centers are often the practice sites for clinicians trained and supported through our programs. HRSA-funded health centers are community-based and patient-directed organizations that serve populations with limited access to health care. HRSA's programs, however, are as diverse as the individuals, families, and communities that we serve. Among the innovative programs that we oversee are organ, bone marrow, and cord blood donation. The agency also coordinates activities related to rural health within the Department of Health and Human Services, and for 20 years, HRSA's Ryan White HIV/AIDS program has provided a legacy of care to persons living with HIV and AIDS. Our programs play a critical part in the nation's healthcare safety net. It seems fitting to close my overview of HRSA's programs by noting that our Title V Maternal and Child Health Services Block Grant Program, which is the nation's oldest federal-state healthcare partnership, will be celebrating its 75th anniversary this year. Title V has provided a foundation and structure for ensuring the health of the nation's mothers and children. In closing, Mr. Chairman and members of the subcommittee, tens of millions of Americans get affordable health care and other assistance through HRSA's programs and its 3,000 grantees. We are extremely proud of our programs and look forward to continuing to work with you to provide quality primary care for all. I appreciate the opportunity to testify today, and I hope this testimony will inform the subcommittee's future deliberations on the many important legislative proposals before you, and I would be pleased to answer any questions you might have.
Thank you, Dr. Brand. And Dr. Clark, you were just here to answer questions, right? Okay. So we'll go to the questions, and I'll start with myself and recognize myself for 5 minutes. I wanted to ask about the Veterinary Bill, H.R. 299, because that's one of the ones that I'm particularly concerned about, and I'll ask Dr. Brand. Well, I'll start with you. Your testimony describes HRSA's work to support the training and education of health professionals. I'd like to ask you about HRSA's support for public health professionals. My understanding is that HRSA administers programs to promote the training education in various ways. But how does this relate to this bill in particular? And if you could tell us how certain veterinarians with expertise in public health contribute to the public health workforce.
HRSA already provides support for veterinary schools through our Health Professions Student Loan Program, scholarships for disadvantaged students, our HCOP program, which is Health Careers Opportunities Program, geriatric education centers, loans for disadvantaged students, and our Centers of Excellence programs. So we already have a relationship with a number of veterinary schools. We have also a new provision that would allow us to provide loan support for veterinarians in their support their training should those resources be made available.
And then Dr. Arias and Dr. Tabak, is there anything you'd like to add about the role of these veterinary public health professionals from either CDC or NIH perspectives, if you would? Dr. Arias?
Sure. CDC clearly recognizes the relationship between veterinary issues, emerging issues among animals and then humans. In fact, H1N1 is the most recent example of how it is that what happens with animals is something that eventually can influence humans, which is what we're primarily charged with making sure we address. In addition to that, we continue to face the challenge of vector-borne illnesses. The most obvious of those currently is the spread of dengue fever, which first was a significant issue in Puerto Rico, but now has crossed borders into Florida, and making sure that we engage in whatever it is that we have to do in order to make sure that that spread does not continue. So that one of the things that we are committed to is making sure that we identify and rely on the professional expertise of all those who need to be brought to the table so that we can then address those health issues among humans in an effective way. And veterinary professionals are part of that.
Thank you. Dr. Tabak?
Yes, I can tell you that the NIH, through the National Center for Research Resources, administers programs that are similar to the bill's goals with regard to training in infectious disease and environmental research. These include training programs and career development programs specifically oriented to veterinarians receiving training in biomedical and translational research of public health significance, as well as providing funding for the construction and acquisition of equipment and other capital costs related to the expansion of entities related to veterinary medicine, biomedicine, and public health. Okay,
thanks. Can I ask Dr. Clark? I have to ask you something since you have, that's why you're here, right? On the methamphetamine bill, H.R. 2818, it reauthorizes and enhances residential treatment programs for pregnant women and mothers. What need does this program meet that makes it different from other drug treatment programs? And does the bill only address meth?
We take no official position on the bill per se, but we do recognize that the important issues associated with substance use and pregnant women and the intergenerational transmission of substance abuse-related problems. We know that methamphetamine affects not only children, the families, law enforcement, but the environment. So we have specific programs targeted to pregnant, postpartum, and parenting women, and this bill assists us in addressing that. Since 2002, we, through our existing pregnant, postpartum women program, we've treated almost 4,700 women. 51.6% were pregnant. So this bill allows us to move what we've been doing in the field to change the authorization to include outpatient care and women who are parenting but who are not pregnant, and that's an important thing. I should note that our program has included care for 4,000 children, 58% of whom were in their mother's custody. So that becomes an important issue because, as we are aware, reuniting families is an important issue where possible. So this bill would allow those issues to be addressed, and we are very much concerned about that, making sure that families can be reunited. We deal with the substance abuse issues both in residential and in outpatient settings, and the authorization associated with this bill broadens the scope of our current activity.
Okay, thank you. Mr. Shimkus.
Thank you, Mr. Chairman. I'd like for you, Dr. Brand, Dr. Arias, please send my warm regards to the Secretary and let her know I look forward to her coming sometime. She will eventually get here, and we will eventually have an interesting day of addressing questions and concerns about implementation. And it's important because a lot of our consternation here is that the dust hasn't settled on the law. The new law does give the Secretary a lot of authority and money to do a lot of things that a lot of these bills could do without authorization. So that's of concern. That's the point of some of these questions. Let me go to Dr. Arias first. I understand the CDC has been involved with arthritis research, education, and surveillance, including the implementation of a national arthritis action plan. Would you describe these activities for us?
I can get you more specific information that I think is going to be more helpful to you for the written record, but just broadly, it is to primarily provide education about arthritis and then encourage the linkage of individuals afflicted with arthritis to services that may be important for them in order to improve the quality of life. One of the significant concerns among individuals with arthritis, especially with increasing age, is the high risk for falls. And then, unfortunately, the negative health consequences associated with that. So not only because of the arthritic issues per se, but then the consequences for general health that unfortunately are true for those individuals. Our program then expands and looks at those issues as well.
So we already have a plan to some extent, is that correct?
I can get, to the extent that we have a plan, I'll send that to you as follow-up. I know that we have the broad strategy is to be able to then identify individuals who are afflicted and make services for either prevention.
When you also do this, can you send us how much money CDC is currently spending on this plan? We think you do have a plan.
Certainly, we can do that.
So issue 2 on this is part of the arthritis bill talks about a $19 million funding for rheumatologists, pediatric rheumatologists. And it's our understanding, in fact, I have it pulled out here. Here's the big law, and here's the page. But in Section 5203 of the new health care law, there is, looks like $30 million loan repayment program for pediatric specialist loan repayment program. This also could be available for, I mean, it's a pediatric specialist, or pediatric rheumatologist would be a pediatric specialist, would it not?
Yes, although I couldn't speak to a repayment program, and I don't know if her...
Well, that's why we need the law. That's why we need the Secretary here, because that's the part of the new law. So, Dr. Brand?
Well,
it's 5203.
Yes, sir. Creates the Pediatric Specialist Loan Repayment Program, and HRSA does manage the loan repayment programs. I don't believe any resources were made available for it, so it's...
Well, there's $20 million for each of the fiscal year 2010 through 2013, which is part of the law that we passed.
Wait, excuse me, would the gentleman yield just for factual?
Sure. Yeah, yeah.
All right, let me just say that the $30 million that was originally in 2010, the HR 2010, has been taken out, so it's out of the bill, the bill that's before us now.
Yeah, yeah. You're talking about the $19 million. This is the health care law that we signed, that was signed in.
No, I understand that, but there's no redundancy. I just wanted to make that point. In case
well, we have, unless you pulled it out from what we were provided right before the hearing. It's in here now. But, well, hopefully, then as we move forward, if that's our question. That's part why we have hearings, to try to address redundancies, and if that's the case, we appreciate it. I also need to move to Dr. Arias again. In fiscal year 2011, the CDC budget justification request includes an increase of $79.4 million above the fiscal year 2010 omnibus for the World Trade Center program, for a total of $150 million. Your budget justification states, with this increase, CDC will continue to provide monitoring and treatment services for mental and physical health conditions related to World Trade Center exposures for both responders and eligible non-responders. The World Trade Center program is critical in meeting the ongoing and long-term special needs of individuals that were exposed to smoke, dust, debris, and psychological trauma from the World Trade Center attacks. This increase will enable CDC to continue providing these much-needed services. The question, some members are apparently unaware that CDC currently provides monitoring and treatment services for first responders of the World Trade Center related attacks. So can you confirm that CDC does, in fact, currently provide monitoring and treatment services?
We don't provide services. We do provide technical assistance to development of the registry and then the surveillance of individuals who were exposed and whatever health conditions they may present. But we don't provide the services.
And the services are provided where?
The services are provided in New York City by community-based organizations, hospitals in that area.
Great, thank you. And my time's expired, but I'll just put on the record, the First Lady's Let's Move program is a program that's not authorized, but is funded by by HHS through, I guess, some by just some discretionary funding and the like. So the point, again, for us is a lot of these things HHS has the authority to do, can do, and just put that on the record, and I'll yield back my time.
Our Vice Chair, Ms. Capps.
Thank you, Mr. Chairman. As some people know, I've been a very proud sponsor of the Heart for Women Act since 2006. And a big component of this legislation is expanding the CDC's Wise Woman program, which you referenced, Dr. Rios, in your testimony, which screens low-income, uninsured, and underinsured women between the ages of 40 and 64 for cardiovascular disease. The program also provides outreach, referral, education, and counseling to the participants. Dr. Rios, would you please speak a bit about the success of the Wise Woman program? Is this considered a valuable and effective program, and does the CDC favor expanding it?
We're very excited about the opportunity for more women to have access to basic screening and other preventive measures starting in 2014. We look forward to Wise Women continuing as a vital complement to those services. Wise Women currently provides for specific health screening, but it's actually a broader effort to improve heart health among women. So that in addition to those clinical preventive services, women in the program can also take advantage of lifestyle programs that target poor nutrition, physical inactivity. Smoking includes programs such as cooking classes in order to improve nutrition, not just of those women, but their families, fitness classes and competitions, and quit smoking classes. These are elements that are not part of clinical preventive services, and therefore we are committed to continuing making sure that these are provided and supported, since there is a significant need for them. It's important to recognize that having insurance coverage doesn't necessarily mean that individuals receive recommended preventive services. So from our experience with a Wise Woman, especially in the breast and cervical cancer screening program and our immunization program, we understand that it takes much more. And so we're looking forward to be able to provide even greater comprehensive response to a leading cause of death for women in the U.S.
Thank you. Actually, I will follow up with the question, but you kind of answered it. There are some who are saying, question whether we need an expanded role for Wise Women program into the future, because both immediate and long-term, as after 2014, when most of the new health reform law goes into effect. It talks a little bit more about ways that you see this being complementary and not duplicative of the primary care that we expect everyone to be accessing.
Yes, you're correct, and that's our intention. And it has been We are very interested in making sure that we coordinate with clinical services, as we should, in order to have a good response to health conditions. However, from a public health perspective, that's not our primary focus. It's really looking at the context in which those clinical services are made available and are accessed by individuals that can be supported in ways that the services themselves will not do.
So this is one of the areas, and I imagine that there are very many other ones as well, where programs in the community that are based in the community that serve particular populations will only be enhanced by having more of your target group now also receiving primary care, and that this will be a symbiotic relationship rather than one competing or in any way duplicating what the other is doing. Rather, it will help to reinforce and actually extend the value of primary care that hopefully more women will be getting for themselves and for their families.
Yes, that's exactly correct, and a major reason for why I said that this is a very exciting time for public health as we look forward to how it is that we can bring down costs, we can improve the quality of life for every man, woman, and child in this country.
Thank you very much. I yield back, Mr. Chairman.
Gentleman from Pennsylvania, Mr. Pitts, and we went and visited your district to see the University of Pennsylvania, what do we call it?
Veterinary school.
Veterinary campus when we were looking at the at Tammy's bill.
Yeah.
We went to the farm, all the farms. It was very interesting.
New Bolton Center. Yeah.
Yeah.
Large animal farm. Yeah.
It was great.
Great. Thank you. You're welcome to come anytime. Thank you, Mr. Chairman. Dr. Arias, you mentioned the 211 in passing and describe it as a bill to implement a state-based call-in system providing individuals with information about human services. Implement infers these programs do not exist. Are you aware of the programs that do exist? 47 states already have these programs.
We know that states have been moving in the direction of providing similar types of programs. Our staff have been primarily involved with committee staff on figuring out what is the best way of implementing the bill if it should move forward in order to capitalize on what already has been done and build upon what has been done.
Does the administration support H.R. 211?
There is no official policy on this bill or any of the bills actually that we are discussing today. It's a complex sort of decision-making process in terms of what are the kinds of things that will get supported and done, and it usually involves then coordinating among all of the agencies within the department and then within the administration, and that process has not been complete.
Would the services provided by the 211 bill be considered an HHS Health Services Program?
Does HRSA want to comment on that?
Dr. Brand?
In terms of health services program, Health Resources and Services Administration, it's not, as I understand, it's directed towards the CDC for the management of it. It's not something that HRSA would do. There is certainly an interest in ensuring that folks have access to information about health and human services for the underserved, and this is one vehicle for accomplishing that. But the department hasn't taken a position on this.
211 programs are currently funded by states, and some states have chosen to allow these services to make referrals to abortion service providers. Many believe that the federal taxpayer funds should not be utilized to subsidize or refer for abortions. Would H.R. 211 allow states to receive federal funds for 211 services and those services refer patients to abortion service providers?
Most likely we will be consulting with other HHS agencies and other administrative agencies before making that determination. And again, the issue is whatever then is allowed by law one and the other by administrative regulations is what we will look to in terms of deciding what kinds of services actually do get covered and what wouldn't get covered.
Okay, H.R. 1347 requires HHS to establish concussion management guidelines that address the prevention, identification, treatment, and management of concussions in school-age children, including standards for student athletes to return to play after a concussion. How would these guidelines differ from CDC's Heads Up program that Dr. Kapil testified about last week at the subcommittee's field hearing in New Jersey?
The Heads Up program is a specific campaign to educate professionals and educate parents and athletic personnel on how to number one, how to recognize concussion, how to manage them. The bill, my understanding is that it would be an extension of that. Currently, we have provided those materials. We have generated those materials. They are available for use, and that's as far as we've been able to take that program.
In developing the Heads Up educational materials, did CDC consult with outside experts?
We did consult with both professional and then with education and with sports professionals in the context of the educational sector as well.
Does CDC have a grant program to states to conduct injury surveillance and develop strategic plans and engage in coalition building work to address injuries?
We have a broad program to address, to essentially support state, local health departments. A lot of, or a significant number of the activities that they engage in is surveillance activities for a number of issues within both unintentional injury and intentional or violence.
Okay, and does, go ahead. Were you finished?
I was going to add.
Go ahead.
It's a very small program. It's not a very comprehensive program. Currently, there are only 30 states that are being supported for a small amount, and again, they usually then often have enough to just support on the or to just focus on the surveillance activities.
Okay, my time is up. Thank you, Mr. Chairman.
The gentlewoman from Wisconsin, Ms. Baldwin.
Thank you, Mr. Chairman. Before I begin my questions, I'd like to submit 4 items for the record. The first is a letter of support for H.R. 2999 and the manager's amendment that we'll be offering during tomorrow's markup. The second is a small section out of the 1999 World Health Organization report titled Future Trends in Veterinary Public Health. And specifically, I just want to put into the record the scope of VPH in the 21st century, because it contains a definition of veterinary public health that I think will be helpful to have in the committee record. And then 2 additional items in support of H.R. 6109. The first is testimony of the Human Rights Campaign submitted by Joe Solomoni's president, and also a article entitled How to Close the LGBT Health Disparities Gap from the Center for American Progress.
Without objection, so ordered.
Thank you, Mr. Chairman. First, I'd like to, I'd be interested in answers from all of our witnesses on this question, but perhaps we could start with Dr. Arias to respond more generally and then move to Dr. Tabak for an update on the Institute of Medicine's work. But is it your belief that the department's current understanding of LGBT health is sufficient to inform federal initiatives to reduce health disparities? Would legislation to ensure the voluntary collection of data on sexual orientation and gender identity as appropriate and practicable in programs and surveys that are supported by the Department of Health and Human Services help to improve and expand the department's understanding? Start with you, Dr. Arias.
Thank you. One of the things that if you sort of hang around with epidemiologists for any amount of time, you very quickly learn that measurement is a key issue. Whatever gets measured is addressed. What doesn't get measured doesn't exist and doesn't get addressed. One of the things that one of the challenges that we face is not knowing and not having a sufficient understanding of LGBT health. CDC is committed not only to promoting and protecting health, but making sure that we address whatever health disparities or inequities may exist. And unfortunately, currently, we don't have enough information to be able to identify what those disparities are.
Thank you. Dr. Tabak? Could you give us general comments on any update you have on the Institute of Medicine's inquiry into this matter?
Yes, thank you. As you know, NIH determined that more information about research needs and gaps in this area were needed, and so commissioned a study by the Institute of Medicine, who's conducting a study and will be submitting a report on the state of knowledge regarding LGBT health, health risks and protective factors, and health disparities, and we expect that report in the spring of 2011. There are many challenges, obviously, that remain to conducting research and address health disparities in LGBT populations, and so we are looking forward to the IOM report and continuing to work with the research community to address the research gaps and opportunities in this area.
Thank you. Dr. Brand?
Yes. HRSA agrees with CDC and NIH, and we don't think we have sufficient understanding of LGBT issues, and we look forward to working with our colleagues at CDC and NIH to better understand those issues.
We are also talking a little bit about veterinary public health and HR 2999. Dr. Brand, you were asked a little bit about current existing loan repayment programs in HRSA. I'm specifically interested in how effective those have been in recruiting and retaining public health veterinarians. How many public health veterinarians have been able to access these funds, and is it your belief that you are reaching the full universe of public health veterinarians who could be working to meet our nation's public health needs?
It's clear that there are shortages of public health providers in all of the disciplines, and certainly this is one of them. I would have to go back and ask my colleagues at HRSA to find out how effective we've been at reaching folks through these programs. These programs do a variety of activities. They recruit individuals, encourage them to go into health careers or stay in health careers or help offset their student expenses. And it's not the direct loan that perhaps is suggested in the bill.
I would just add briefly, we had a hearing on the full bill last session, and it was so illuminating for me to realize how critical public health veterinarians were in responding to human health threats. I mean, you wouldn't think of it intuitively, and then we found out so much about that. It is my understanding that a very small fraction of the currently available funds are actually directed to public health veterinarians, and we'll follow up after in making the record full. But I'm delighted, Mr. Chairman, that you've chosen to put this bill on the hearing docket as well as the markup docket for tomorrow.
Thank you. Mr. Burgess.
Mr. Chairman, before I start my time for questions, I'd like to be recognized for a unanimous consent request.
You're recognized for whatever you like.
Mr. Chairman, I'd like to ask unanimous consent for the letters that we've received in support for the National Neurologic Disease Surveillance System Act of 2010 from the Alliance for Aging Research, the American Academy of Neurology, Dystonia Medical Research Foundation, National Multiple Sclerosis Society, Parkinson's Action Network, Research America, and the MS Coalition, the American Brain Coalition, to be entered into the record.
Without objection, so ordered.
In addition, I ask unanimous consent for the letters we've received in support for the Gestational Diabetes Act of 2010 from the American Association of Colleges of Pharmacy, the American Diabetes Association, the American Association of Diabetes Educators, the American Congress of Obstetricians and Gynecologists, the American Medical Women's Association, the Association of Women's Health, Obstetric and Neonatal Nurses, and the Society for Women's Health Research be entered.
Without objection, so ordered.
And finally, I ask unanimous consent that the letters we've received in support for the Birth Defects Prevention Risk Reduction Awareness Act of 2010 from the American College of OB-GYN, Allergy and Asthma Network, Mothers of Asthmatics, American Academy of Allergy, Asthma and Immunology, the American Academy of Pediatrics, the March of Dimes Foundation, Spina Bifida Association, and the Spina Bifida Foundation, and the Organization of Tetralogy Information Specialists be also entered.
Without objection, so ordered. Oh, I see. You were trying not to have that count toward your time. Was that the idea?
I have learned under your guidance, Mr. Chairman.
I see. Okay.
And I'd also ask unanimous consent that my opening statement be entered into the record.
So
I apologize
ordered.
for not being here at the start of the hearing. Let me just ask you a question, Dr. Arias. You just said what gets measured gets addressed, in response to a previous question. Would you also agree that if we measure to address, registries will help tell us how we're doing?
Part of our interest in surveillance activities is not only to identify what the problems are and who needs to be served in order to address those issues, but then also over time to be able to measure the effectiveness of whatever solutions are implemented or tried.
So in other words, to make better decisions on how to spend the research dollars.
Yes, sir.
So the cost of providing these tools for surveillance would be a wise investment so that we have the useful data and make actually the federal government better stewards of the billions of dollars of taxpayers' money that are spent on medical research.
Yes, certainly at CDC we do try to be good stewards of how it is that those federal dollars are invested. Again, the major issues that we look at when we make those decisions is, number one, what is the burden? And so is it a significant problem that, if addressed, is going to address the greatest number of people? But then the other is, do we currently have strategies, evidence-based strategies that will allow us to intervene? And so usually those two are critical issues, and then making sure that that investment is an optimal one.
And Dr. Tabak, from the NIH perspective, would you agree with that a surveillance system does help us measure, not just measure, but tell us how we're doing with those things that we are measuring?
Well, as you know, the CDC is responsible for surveillance, but certainly that helps inform the situation. Yes, sir.
Well, referencing here specifically 1362, the National MS and Parkinson's Disease Registries Act, and I trust, have you all made available to you the amendment in the nature of a substitute that will be submitted during the markup later when we do that? Is that information that you have available?
I do not, sir.
Well, again, the concept would be to allow scientists to better leverage efforts to find better treatments and cures for this compendium of neurologic diseases. Again, Dr. Arias, I would assume that you would be in agreement with the general notion of that.
Yes, we are. Generally, we are very supportive of and look for opportunities to cover as many things as we need to in order to be able to, again, make those sound investments with either current surveillance systems or the development of those surveillance systems over time.
And then, Dr. Tabak, as we get further into development and understanding of the human genome, we'll be able then to cross-reference back to these surveillance systems or registries in order to help more patients and perhaps identify additional risk factors that were not previously anticipated.
Yes, of course. As you identify genetic linkages through genome-wide association studies, the idea then is to circle back to patients to see how generalizable things are. And in fact, there is research currently being supported by NIH in this arena.
Let me, Dr. Harris, let me just ask you, moving on to the Gestational Diabetes Act of 2009, HR 5354, are there currently any demonstration grants going toward gestational diabetes education?
We're currently working to strengthen state capacity for diabetes prevention programs. Prevention of 2-type diabetes is an outcome of addressing CDC's winnable battle of obesity, nutrition, and physical activity. We do not have a specific gestational diabetes component to that, but are committed to addressing whatever the needs are within the broad framework of diabetes prevention.
So you would agree that having a specific effort to look at gestational diabetes is an important part of our overall diabetes management?
Again, what we would do is, based on whatever science is available at that point in time, at any particular point in time, giving us a good picture of where the issue is and what can be done about it to determine where is the best place to try to intervene.
Let me just ask you, Dr. Arias, one last question in regards to HR 5462, the Birth Defects Prevention and Risk Reduction and Awareness Act. Are you familiar with the pregnancy risk information services as they exist in a handful of states, such as my home state of Texas?
Yes, and we do support just a handful of states to actually collect information and do some educational work on pregnancy-related issues and birth issues.
Well, I mean, I was a practicing OB-GYN for 25 years before I came to Congress. I'll just tell you, there are precious few places to go for the practitioner. And this really came home to me last August. We're all gearing up for H1N1 and what the impact of that was going to be. And in fact, on the phone with researchers at NIH one day, and really felt for the practitioner out there in the communities who was going to be seeing a great number of school teachers who possibly could become pregnant during part of the school year, who were going to be teaching young children who might be reservoirs of H1N1. And it really was a conundrum about how to advise this large subset of the population. Do you seek a vaccination, or is this something that would be countermanded by the pregnancy? And it really put a big burden on providers, and I could sympathize with the questions that they were going to get in a week or two when the school year started, and women came in and were questioning whether or not they should have the vaccine, and if they in fact knew they were pregnant, if the vaccine would be harmful. So it is so important to have this type of information that is literally just a phone call away when people are faced with making tough decisions. I do hope that you'll look on this legislation favorably. I think it is an important part of our armamentarium of what we provide, the services we provide to not just to our patients, but our providers out there as well. And thank you, Mr. Chairman, for your indulgence. I'll yield back the balance of my time.
Thank you. Oh, no, you went 2 minutes over, but that's okay. We have a lot of time today. The gentlewoman from Colorado, Ms. DeGette.
Mr. Chairman, I just want to thank you for having this hearing today, in particular on the two bills, which I'm the primary sponsor, the Pediatric Research Consortia Establishment Act, H.R. 758, and H.R. 1995, the Eliminating Disparities in Diabetes Prevention, Access, and Care Act. And I also want to thank you for bringing up Mr. Space's H.R. 6012 Diabetes Screening Utilization Bill. These are all important bills that we've been working hard all year to try to pass. I also want to ask unanimous consent to introduce two letters, or for the record, two letters, one on H.R. 1995 from the American Diabetes Association, and the other one on H.R. 758 from the Federation of Pediatric Organizations.
Without objection, so ordered.
Thank you. And I guess I can retroactively yield 2 minutes of my time to Mr. Burgess. And
You're
with
really
that, that, I'll yield back.
Thank you. No, don't. No, she wasn't serious. Next is, what about Doris? Oh. The gentleman from New York, Mr. Engel.
Thank you very much, Mr. Chairman, and I stand behind everything that Dr. Burgess said. He and I have a bill which we are talking about today and we'll be voting on tomorrow, the Gestational Diabetes Act, known as the GEDI Act, which we sponsored together. And I just want to, since I didn't make an opening statement, make a mini opening statement now and just say that 135,000 women in the U.S. are diagnosed with gestational diabetes each year, and it can occur in pregnant women who've never had diabetes before, but who've had high blood sugar levels during pregnancy. And while gestational diabetes generally goes away after pregnancy, it can have significant health impacts upon both the mother and baby. In particular, women are at much higher risk of developing type 2 diabetes in the future, and their children are at higher risk of obesity and or the onset of type 2 diabetes as adults. That's why we introduced this act, and the bill aims to lower the incidence of gestational diabetes and prevent women afflicted with this condition and their children from developing type 2 diabetes. We need to have a greater understanding on how to prevent and treat this condition. There is currently an insufficient system for monitoring cases of gestational diabetes to uncover trends and target at-risk populations. In addition, new therapies and interventions to detect, treat, and slow the incidence of gestational diabetes need to be identified, and our bill will help us accomplish these goals. I know Dr. Burgess mentioned that all the groups that support this legislation, I'm going to mention them again: the American Diabetes Association, the American Association of Colleges of Pharmacy, American Association of Diabetes Educators, the American Medical Women's Association, the Association of Women's Health Obstetric and Neonatal Nurses, and the Society for Women's Health Research. Mr. Chairman, if Dr. Burgess hadn't done it, I think he did, as I was coming in the room, I would like to request unanimous consent that the letters of endorsement be entered into the record. So,
I believe they all have.
Okay, thank you. And let me ask Dr. Arias, based on what I have said, can you tell me what support and outreach programs are currently available to those with gestational diabetes? And also, is there currently a system in place to monitor cases of gestational diabetes?
Monitoring gestational diabetes specifically would be a new activity for us. As I mentioned earlier, we do comprehensive diabetes prevention work, and in the context of that, if the issue gets raised, then we devote whatever resources we may have in order to address the issue.
What more can be done in these areas, in your opinion?
At the risk of being repetitive, it is surveillance and making sure that we're very clear about not only the extent of the problem, but where the problem seems to be most and where it is that we need to focus in order to be most effective in addressing the issue from a population-based perspective.
Thank you. Let me ask you one final question. Can you speak to the unique differences between gestational diabetes and other forms of diabetes like type 2? And is there a way to determine if a woman's at high risk to get gestational diabetes?
I'm afraid I'm not a subject matter expert, and that's information that then we can follow up and send you.
Okay. Can anybody else attempt to answer that at all? No? Okay. Well, I hope, Mr. Chairman, I'll yield back the balance of my time. I hope that that the committee can tomorrow unanimously pass this. This is obviously not a partisan bill. This is a very bipartisan bill, and gestational diabetes doesn't happen with people belonging to one political party or another. It happens to Americans, and I think this is something whose time has come. We need to address this very serious issue. I yield back.
Thank you, Mr. Engel. The gentlewoman from California, Ms. Matsui.
Thank you, Mr. Chairman, for holding today's hearing. And before I begin, I'd like to ask unanimous consent to submit these letters of support from the National Marrow Donor Program and the Aplastic Anemia and MDS International Foundation for the record.
Without objection, so ordered.
I'm so pleased that two of the bills that are most important to me are included in this hearing. Together, H.R. 1230, the Bone Marrow Failure Disease Research and Treatment Act, and H.R. 6081, the Stem Cell Therapeutic and Research Reauthorization, represent a holistic approach to combat bone marrow failure diseases. If enacted, they will address new critical areas for research, build awareness of the diseases in high-incidence communities, and provide for a one-stop shop for adult stem cell treatment options. Dr. Tabak, one of the aspects of that H.R. 1230, the Bone Marrow Failure Disease Research and Treatment Act, would provide for coordinated outreach and informational programs targeted to minority populations affected by these diseases, including information on treatment options and clinical trials research. Can you speak broadly about the challenges associated with ensuring minority participation in clinical trials?
Yes, thank you. We issue a 5-year strategic plan on health disparities, which describes the agency's priorities for addressing minority health and health disparities. And as part of this, the new institute, the National Institute of Minority Health and Health Disparities, has committed to ensuring greater representation and participation of racial and ethnic minority populations, as well as other health disparity populations in research activities. And they've done this through the establishment of a bioethics research infrastructure initiative, which is a network of bioethics centers around the United States, both academic and other private nonprofit entities with a history of research and training engagement with health disparity communities provides a perfect platform for this initiative. And through this initiative, the NIMHD has dedicated about $15 million in Recovery Act funds over the past 2 years, 09 and 10.
Dr. Tabak, is it true that it's difficult getting minority participants in all sorts of clinical trials, and it's important to have research relevant to all groups?
It is very important to have research relevant to all groups.
Okay. Dr. Brand, I appreciate your mentioning these bills in your testimony. You mentioned that there are 6,000 people searching for a matched bone marrow donor or cord blood unit at any time. Can you explain the relationship between the increased research and public education campaigns included in H.R. 1230 on the potential future successes for the C.W. Bill Young cell transplant program?
H.R. 1230, the Acquired Bone Marrow Failure Treatment Act, provides for research on acquired bone marrow diseases, encourages outreach, and directs the Agency for Healthcare Research and Quality to examine best practices regarding diagnosing and providing care to individuals with acquired bone marrow disease. To do this, the Secretary may rely partly on the Stem Cell Therapeutic Database, which is authorized by H.R. 6081, the Stem Cell Reauthorization, the C.W. Bill Young Cell Transplantation Program, and the National Cord Blood Injury Inventory increase the number of transplants for recipients suitably matched to biologically unrelated donors, and supports the collection and storage of a genetically and ethnically diverse inventory of high-quality umbilical cord blood for transplantation. Additionally, the education and outreach called for in H.R. 1230 would help assist patients understand all their treatment options, including transplant, and help patients and physicians assess transplant as a treatment option early in the course of their disease. Optimal transplant outcomes are more likely to occur if the transplant is done before the patient's health has deteriorated significantly.
And Dr. Brand, one way to measure the success of the C.W. Bill Young cell transplantation program is through the number of transplants performed. Can you tell us how the program has performed in this manner during the last 5 years in terms of the actual number of transplants, as well as the actual performance when compared to the part goals?
Cord blood stem cell transplants exceeded goals of 4,500 in 2010, and we've reached over 5,000. Transplants for minority patients are up sharply. We've exceeded our goal of 636 in FY 2010, and we will facilitate 840 by the end of the fiscal year. And I can provide you a 5-year summary for the record, but we have exceeded our targets every year.
Thank you. And one more question. Another important indicator describing how the program operates is survival rates over time. How have the survival rates over time changed for the unrelated transplants that the program facilitates? How do they compare to transplants for related donors?
Survival for standard risk patients now is at 70% at 1 year after transplant, compared to 50% in 2000 and 42% in 1988. And standard risk patient survival after unrelated donor transplants now matches that for sibling donor transplants.
Okay, thank you, and I yield back the balance of my time.
Thank you. Gentlewoman from Illinois, Ms. Schakowsky.
Thank you, Mr. Chairman. I just have a couple of questions. Ms. Arias, I wanted to ask you, there are, as you know, there's 46 million people who suffer from arthritis, but in 2008, only 12 states received funding for programs to prevent and control arthritis. How were these 12 states determined? I understand that 40 states applied, but only 12 were funded.
Yes, that is correct. We only had enough funding for 12 states, and those were chosen on the basis of a competitive process. So it was an evaluation of the applications, and then the highest, strongest applications then, until we ran out of money, essentially were supported.
But not all, would you say that the others were not worthy necessarily, or?
No, not necessarily. What essentially, we had a limited pot of funds and could not fund any more than the 12 if we had wanted to. There were other applications that were worthy of funding and were recommended for funding. However, there weren't any funds available for that.
Well, along the same lines, Dr. Tabak, did I say that right? Okay. In your testimony, you describe the process that NIH uses to set priorities and says, and you say that, quote, the rigor of this process is so competitive and the number of applications is so large that today fewer than 1 in 5 research proposals receives NIH funding. So again, I want to ask you, does this mean that only 1 in 5 is worth pursuing, or again, is it funding limits prevent the approval of research proposals that really do have the potential to be worthwhile?
The latter. We certainly, if we had the resources, would be very proud to support additional applications that we receive.
Okay, well, thank you, and that's why I look forward to the markup on HR 2010 that deals with arthritis, which affects so many Americans, and see if we can't get some of these other worthy projects, and more particularly, we're short of pediatric rheumatologists to try and get more of those to address this problem. Thank you, and I yield back.
Thank you. I think all members have had a chance to ask questions. Unless anyone else, well, let me thank you first of all for being here, and appreciate your input on this. And as you know, we plan to move to markup tomorrow, so it was very useful to have you here today. Thank you very much. I don't know if anybody said they had any written questions they were going to send you, but they could still get you could still get some written questions from members, and we'd ask you to get back to us quickly. Anyone else? If not, without objection, the meeting of the subcommittee is adjourned.